So this is our last segment, guys. This segment is going to take us kind of on a bit of a departure from kind of the core direct primary care theme that you've seen through a good part of the day. We've got some very different perspectives that are also incredibly important and valuable into the kind of the broader direct care phenomena that's happening, direct primary care being a component of that. And we're going to do, kind of like the same format we had a little while ago, 3 speakers, lightning talks, in other words, about 5 to 10 minutes, kind of intro, some background, key points, and then a panel discussion. So a chance to interact with them. Our first speaker is Tamara Khan. Tamara is a co-founder and CEO of an organization called Cure Health. And they are specialists in creating bundled pricing solutions for surgeries, amongst other things, but that's their core competency. And as you heard a lot about today, direct primary care organizations are increasingly looking to bring in other price-transparent, low-cost, cash-pay solutions beyond primary care. Tamara's building a lot of that kind of future world today, and she wants to talk about how she's doing that and what she's up to. So with that, Tamara.
Hi, everyone. Thanks for lasting towards the end of the day. I'm glad to see all of your faces are still here. Thank you so much for all of the great learnings today as well. I've been really, really enjoying all of the talks and conversations. It's been really fantastic. And I'm really excited about kicking off this next session, talking about how we can start collaborating with primary care to extend the services that you're offering your customers. So a little bit of disclosure. I used to work for a payer. In fact, I used to work for a lot of payers. Still recovering. And one of the really meaningful moments, and I'm super proud of the work we did, I think you guys will probably give me a pass. We were trying to create more transparency and actually help payers meet their Affordable Care Act requirements of offering transparency to their members. But there I was, a couple years in, having built this really incredible tool to start making sense of the mess that was healthcare claims in this country, sitting on about 1/3 of the country's claims, and having the unfortunate realization that patients, especially those in high deductible plans, were continuing to struggle to find the care that they needed. So it was definitely one of those moments where it was not a build it and you will come. What we found was that as we sort of dug in, 2 consistent themes emerged. And one of them was that patients, while really, really wanting access to transparent pricing, didn't necessarily think that an online tool from a payer was good enough. And as I was digging in and looking at the lines of influence and thinking about who is actually driving a lot of these decisions, over and over, every arrow pointed at the physician. And it was the physician that really was the place where patients wanted to have these conversations about value. It was the place where patients wanted help and guidance making these trade-offs about, should I really pay extra for this? Is this really worth it? Do I need to get this care now, or should I wait for later? And that was a big realization for me, having spent 2 years of my life building these tools, and coming to the realization that it was an entirely different stakeholder that needed access to this level of transparency. The other really interesting thing about having access to 50 million Americans' claims data was that there were some really interesting opportunities to save. The consistent pattern that we saw in the information, and this is not going to be a surprise to any of you, is that cost not correlated to quality, and the delta is really large in particular types of care. And specialty care was amongst the highest. So before I continue, I want to ask everyone here a question, which is, first, how many of you are in some kind of value-based arrangement where you're somehow financially responsible for your referral choices? Any of you in this room right now? Not one, couple. How many of you feel responsible for helping your patients find affordable care? Yeah. And I think, as we sort of, I think we'll hear from Sally a little bit later, there's definitely trends towards moving to a place where folks are becoming increasingly on the hook for the referral choices that they make. And when we put providers on the hook for referral choices that they make, we haven't been historically equipping them with the tools they need to actually make effective decisions. And so the core of Cure has really been founded on the idea that we're going to try to tackle that problem and try to help find paths where we can help providers steer patients towards those parts of the system where there's less fat. So specialty surgery was one of these big, big vectors for cost savings opportunity. And the reason was all those red parts of the pie chart. Huge amounts of dollars going to corporate profit, exec compensation, unnecessary administration. And that's not even counting, the unnecessary administration down at the bottom isn't even counting the additional 17% MLR that the payers are throwing on top of the types of services that we provide. And when you look at the chart and you sort of see, of the $700 billion plus that an additional $125 billion that the payers then charge, what you're starting to see is the provider earnings make up a very, very, very small chunk of that. And there's no one in this room, because you guys already know this. There is no reason that a single surgery where a provider is making maybe $1,000 on the case, maybe $500 on the case, would require that much overhead to pay for rent, administration, and the biller. And for those of you who care about getting your patients to more affordable care, the problem isn't just the specialty care provider. The problem is also your problem. You have to decide what specialty care provider you're going to send your patients to, and then that person has to figure out what facility they're going to admit to, what implants they're going to use, what supplies they're going to pull out of the cabinet, and they have almost no tools to do that. And bundles are really, really, really interesting solution to this problem. They've certainly proven to have driven a lot of financial savings with some of the new pilots going on with the BCPI program through Medicare. But as we started to notice these products come onto the market, one of the most interesting things that we've discovered is that there's even more opportunity for savings. And one of those is really looking at the way bundles are structured. So one of the things many of you may not know, and some of you may, is that the vast majority of bundles or bundle programs in this country are currently centered on a facility. And if we remember the last slide about who is profiting, we see that the facility is actually a really, really, really big determinant of cost. So the question becomes, why would you have the fox guarding the henhouse? Our belief is that if we're going to create a sustainable product that's going to work in direct care, we need to do more. We need to start delivering care bundles that take a page from the book of direct care primary care and start incentivizing specialty care surgeons to direct care along the specialty care episode. And what I'm going to do is I'm actually going to walk through sort of a design review. I'm asking you guys for a design review. What I'd like to do in the rest of this talk is actually walk you through the principles with which we use to design our specialty care bundles. And it's an open invitation. This is an invitation to collaborate with all of you. I want to hear from the primary care providers where we're getting it right and where we're getting it wrong. So we have 7 principles that we've used to design the packages that we are now piloting. And, oh, going the wrong way. The first one is simple standardized pricing. The beauty of this is that the bundle concept already handles this in a lot of ways. The way in which we're extending that concept is we're trying to drive to a place where we stop paying for services and we start paying for cures, which is the name of our company. There's a trend right now where, well, not a trend, but we would hope, I hope that we'll drive a trend to drive cases towards single code pricing. And it's a baby step to the ultimate goal of paying by by diagnosis rather than CPT code. But we've narrowed our bundles down to a single CPT code fee schedule, which really does a great job of standardizing. It's impossible right now for any of the surgeons in our network to upcode, which means that when you refer, you know exactly what the price is going to be. There are no surprises unless somebody entirely changes the kind of surgery that's actually going to happen. The second principle that we really believe in is that specialty care is supposed to be special. The reason you see a specialist is because something unusual has happened. And current methods for bundles look at incentivizing based on population statistics. They look at averages. And it's an effective way of evaluating performance if all you have access to is claims data. But what's really cool about starting to work more closely with providers, or in a program like ours that's actually designed by providers for providers, we can actually go down to a lower level of detail. And we can start to create incentives that are actually allowing maximum decision-making power by the specialty care physicians who are managing a particular episode. The other piece that we are thinking about, which is not just thinking about maximizing decision-making power, but also making sure that incentives are tied to particular cases. So we don't deliver our incentives a year and a half later based on a year's worth of data, which leaves patients in the middle, in the mean, doing really, really well, but patients in the edges doing kind of poorly, which is unfortunately pretty common when it comes to specialty care, because it's pretty easy to say, hey, this is the average for shoulder repair, but then somebody comes in having had a horrible car accident, and the underlying cost of care is just higher. And we want to provide that care. We want to be able to pay people fairly for the real care that they're providing. The third principle that we use to design our programs is targeting the behaviors that matter. In every different specialty, there are different vectors for cost containment. And there's not a one-size-fits-all solution. You actually have to dig into the details and figure out what's really going on and what's driving cost. So I'd like to walk you through an example. This is a pilot that's live here in San Francisco. We are targeting orthopedic surgeons. It includes about 75% of the surgeries that orthopedic surgeons do, orthopedic and spine surgeries, so 75%. We're not just bundling knees and hips, we're bundling everything. The bundles are pretty simple to start. They include the surgeon's fee, assistant surgeon's fee, facility, anesthesiologist, single fixed price. But here, what we're also doing is we're offering our surgeons a single base fee per case, plus an increase in their reimbursement for meeting certain value-based requirements. And in this particular case for orthopedics, in Northern California, we're targeting the specific problems that is facing orthopedics in Northern California. I know it's a novel concept. Site of service, cost savings when it comes to materials and implants, keeping referrals in network, where we have an extremely challenging out-of-network anesthesiology problem. And we balance this with quality. And depending on the program, what's really nice about these balanced incentives is that in some cases, you don't get any of your cost incentives unless your patient gets better. And when we talk about quality, I'm not talking about patient satisfaction. I'm talking about real clinical quality measures, patient-reported outcomes collected before and after surgery that evaluate real function, the kinds of evaluations that should have dictated whether the surgery was appropriate in the first place. And the outcomes are great. The results are fantastic. What we're looking at here is about $275 in incentives. Those $275 in incentives drive anywhere from 32 to 63% in savings. The simple action of paying providers to be cognizant of which facilities are affordable is moving cases from hospitals to surgery centers, which we already understood. But when we add the additional layer of getting surgeons to partner with the facilities to lower materials and implant utilization at the facilities, we basically guarantee that every single case is profitable, which allows us to negotiate the already low ASC fees even lower. It's a virtuous cycle that is the kind of thing where we want to create more of this, and we want to do it specialty by specialty, region by region, to target the issues that are actually facing that particular patient population. The fourth principle that we focus on is making room for creativity. A lot of programs are really rigid. You sign a contract, you stick with it for the year. What we're wanting to do is create flexibility for our providers. If our providers show up with a great idea that really saves cost, we're going to reward them for it. And not next year, today. For example, my co-founder and I have been really excited for a really long time about the idea of moving surgeries out of facilities entirely and more into office-based. He's a hand surgeon. He's fantastic. You should meet him. Greg, he's somewhere here. I don't know. Raise your hand. He's back there. And with hands and feet, there's a lot of surgeries that can happen inside the office themselves. Medicare already pays more in these cases, but a lot of other folks don't. Now, the problem that we talked about with bundles often being linked to a facility means, in most cases, no one has any incentive to actually make that movement. But if you remember that giant bar graph about the facility costs, when you move a case out of a facility entirely, that disappears. And we have good fortune. We have a podiatrist who's decided to tackle this week. And what we're doing is we're revising his fee schedule next week. We're looking at the cost that he's saving. We're rewarding him and increasing his fee for migrating those cases. We're taking a little bit more out to make sure that he has the staff necessary to do those cases at his office. And you know what we're doing with the rest? Most people would keep it. We're just charging less. I know that's a novel concept, kind of crazy, but it seems like the right way to go. That way our patients pay a lower coinsurance, and the employers that are supporting them and bearing the rest of that cost are also paying a lower upfront fee, because there's no reason to be so greedy. There's plenty of money in this $3 trillion healthcare system, and we can certainly reward our providers more, especially when they're coming up with cost containment opportunities that really, really move the needle. Fifth principle, provide actionable feedback quickly. We're doing that on a regular basis. When you do case-by-case incentives, you don't have to wait a year to tell people whether they're doing well or doing poorly. The other big dimension of our program is working towards quality. We measure quality on every case, on, again, patient-reported outcomes. And we know that quality is fuzzy in this world, but there's no reason to accept that. It's going to take time for us to gather the data that we need to start defining real clinical quality measures, but there's no one better equipped than the medical minds in this room. So why not start now? Why not start today? And lastly, and this is something that we're only just starting with, is we're aligning team incentives. When we looked at that $300 that we were paying the surgeon to start moving cases, think about what that $300 is worth when you move down the care team chain. So obviously $300 isn't worth very much to a hospital. It's worth something to a facility, but not, again, not super significant. 20% of increased fees to a doctor, that's nice. But $300 to a nurse, $300 to an OR tech, that's worth a lot of money. That's doubling what they get paid. And these are the people on the front lines of cost containment and quality. They're the people, when we incentivize them as a team, enable us to create accountability and alignment. And of course, there's the PCP. And my invitation, this is the philosophy, a little summary, my invitation to you is, tell me more. Tell me what I've said that's resonated. Tell me what you object to. And let's start talking together about how we can work together to drive costs down. Thank you.